All right, thank you very much. So today is going to be on cardiothoracic surgery and physio perspective, what we need to be doing for our patient, different procedures we can find from cardiothoracic point of view. So let's get started without wasting time. So first of all, I'd like to quickly do a quick knowledge check here. Sorry for the slide, it's a big wider than expected. So I'd like to first of all ask us, how many of us are very familiar in this area? Like we are much more very familiar with this domain. So if we look at the picture in front of us, can you make sense of anything in the picture? Is it looking like something we are quite familiar with? Is it looking a bit scary? Right? Do you think managing this kind of patient, do you think it's gonna be straightforward? Do you think it's gonna be can we mute ourselves so that we can enjoy ourselves, please? Bafaya, can you mute yourself, please? All right. So like I was saying, so what do we think in this area? Do you think managing this kind of patient, do you think it's going to be straightforward? Do you think it's going to be challenging? What sort of things do you think we like to be doing with this kind of patient? My God. Hello, Dr. Idris. Are you still on the call? Are we able to mute these people, please?
W is for watch. M is for watch. M for.
It is Sonny. Can you mute yourself, ma? Oh, sir, sorry.
Okay, so sorry.
Oh, all right, sir. Thank you, sir. Thank you, sir. Thank you, sir. So yeah, thank you for the response in the chat box. Somebody have written that this patient is likely to be in the ITU setting, which is great. Yeah, they might be on cardiothoracic ITU. They might, depending on your place of work, they might also be in maybe general ITU. They could be anywhere. Yeah. So what kind of things do we think physios are likely to be doing? What kind of stuff do we think we are likely to be doing with this kind of patient group? So just pop the response in the chat box, and if you've got any specific experience you'd like to also share with us with patient in this patient in this category with all sort of attachment and all of those things. Yeah. So what do we think, guys? Is it familiar area? Is it some areas we need to, maybe develop more of our skill set and maybe knowledge or something? Anyone ready to share anything on this area? Because it's great that we first of all have this before we crack on, so we know where we are. Yeah. All right, then I will just continue because of time. So okay, before I continue, I'd like to first of all say this, that sincerely speaking, this is a very, very scary environment. This is a scary patient group because of, the life-threatening condition they've got, because of loads of attachments, load of support that they are currently on. But believe me, this is a well-controlled environment. We've got loads of MDT around us. We've got, of course, we've got our own skill set, our own job specifications, our own knowledge based, and a very good things we need to be doing with this patient group. And let me read the chat box. Yeah, somebody has also written, yeah, chest physios are part of what we need to be doing. Of course, big things for us when it comes to what we need to be doing with this patient in this area. Yeah, thank you for that. So like I was saying, it's normal, honestly, it's normal for us to feel scary in this environment. But like I said, I think it's one of those things we need to, develop. We need to think about how we can support patient group, because the reality here is the impact of physios in this domain cannot be underestimated. All right, so let's continue. So cardiothoracic anatomy, cardiac anatomy. We are not here to teach anatomy or to discuss anatomy. We are here for physio. And and again, I want to believe we all have a good, solid foundation in anatomy. So so we won't be sitting and be discussing anatomy here. But few things I just like us to remember from our basic anatomy. At least remember your big artery, remember your aorta, remember your ventricles, and sorry, remember your heart chambers. We've got 4 chambers, your atriums and your ventricles. Remember those things. Remember your coronary arteries as well. Throughout the end of this discussion, we'll be referring to those things. And remember your valves as well, your bicuspid valve, your aortic valve, your tricuspid valve, all of those things. Try to remember them. So maybe just a small stuff here. I know we know these things. So aorta, what they do is just they carry oxygenated blood away from the body, and aortas are if you look into your ventricle, for instance, you've got two ventricles, left ventricle and right ventricles, and of course this left ventricle here will pump blood into the aorta, and it's a high pressure system. We all know all of these things. And again, so a few more things here. Remember your coronary artery, like I said, also very, very important in this discussion that we're here to have today. But I will try as much as possible to keep everything very, very simple and very basic, so that we can make a lot of values from today's presentation as well. So in terms of indications for surgery, so, thoracic surgeries or cardiac surgeries, for instance, there are 3 major indications. You might find if somebody has got disease of the coronary arteries, yeah, that might also warrant them having cardiac surgeries. If somebody have got issues with the valve or disease of the valve, they've got issues with the bicuspid valve or tricuspid valve, or they've got issues with the aortic valve, yeah, that might also be that can also predispose them to have a cardiac surgery as well. So all right, let's move forward. In terms of cardiac conductivity, at some point maybe later in this our in the series of in our series of acute teachings that we've got, I might come back to at some point to discuss about cardiac conductivity and ECG, and I will also try to link that to physio. I won't do that today, but I deliberately put this in these presentations just to get us aware that cardiac conductivity is also something that they are very, very much more relevant to physios. ECG, all those kind of things are really, really very important to us as physios. Maybe later on, I'm going to discuss that in details with ECG. So let's move forward. So in terms of risk factor, let me go back. So in terms of risk factor, so in terms of risk factor, I like to quickly ask us, well, oh my God, please let's mute ourselves, please. It's love it, please.
This breast, no be here.
It's love it. Can you mute yourself, please?
This boy cannot be predicted. Nice. Come and talk. Now they mop.
All right, let's continue. I don't know what to do, and this is taking time now. So like, yeah. So guys, I like to quickly ask all these questions. We are here to discuss cardiac surgery today. So what do we think are the risk factors? What do we think are the factors that can predispose somebody to having a cardiac surgery? Are we able to pop those things in the chat box? Like, what do we think are the likely risk factors that can predispose somebody to having a cardiac surgeries? Yeah, please respond, please. You pop that in the chat box. What are the risk factors? And in terms of preventions, what are those things we can be doing to prevent? Anyone in the chat box? This is easy. It's Beloved, can you mute your mic? Yeah, thank you very much. Pitifumlayo, she's written in the chat box. Yeah, if somebody have got a trilogy of ballot, yeah, great. If somebody have got obesity is a risk factor, great, good one. Yeah, pop responses in the chat box. I'm reading the chat box. Yeah, what are the risk factors for somebody to get? What are the risk factors for cardiac surgery? Because we need to know these things are they are linked with physio. Yeah, high blood pressure, perfect. Great job, thank you, Pity Stella. Yeah, high blood pressure, obesity. Yeah, if somebody have got congenital issues like Pity Fumlayo have mentioned. Yeah, triple vessels disease. Yeah, arterial disease, anything. Yeah, great job. Pop responses in the chat box. Of course, as cardiac physios or as surgical physios or as ITU physios, or so we need to know some of the risk factors because these are also linked with what we'll be doing with the patient after their procedure, if they end up having any procedure, or if they are even on coronary wards now, we are seeing them for even if they are not having any surgery or anything. Of course, we need to be aware of risk factors. Yeah, any other risk factors? There are a bunch of them. There are thousands of them. Yeah, pop some of them in the chat box. Yeah. So are there some of the risk factors that we can modify? Are there some of them that we can't control, we can't do anything about? Yeah, responses, guys. Yeah. So I'll just give us few more minutes in it because it's important we are just here to share knowledge. Yeah, great job. Family history of cardiac disease, perfect. Aortic aneurysm, big one, big factor. Yeah, we're going to discuss about that today as well. Aortic aneurysm. Yeah, good job. Yeah, sedentary lifestyle, great. Reduce physical activities, all those things. Yeah, obesity, perfect. Obesity is modifiable, perfect. Great job. Yeah. Can we have few more of them? Great. Are there some of them we can also do anything about that we can control? Are there some of them that we need to be aware of as physio as well? Get your response in the chat box. Yeah. Because we need to know all of these things. Yeah. So I will just move on to the next slide. Thank you very much for that participation. That's super impressive. So in terms of risk factors, like I said, it's something we can partition into two. We can have some factors that we can control, we can modify it, and we can have some of them that they are not modifiable. You can't do anything about it. For instance, if you are a male, you can't do anything about that. So if you are female, you are female. Yeah, and I understand these days there are some, but yeah. But so in terms of non-modifiable risk factor, you can modify your age. You can, of course, your sex. Of course, male also have more high chance of having cardiac surgery as opposed to female. So so in terms of non-modifiable risk factors, you can talk about this obesity, smoking, diabetes, blood pressure, stress, sedentary lifestyles. All of these things are non-modifiable. They are modifiable risk factor. Yeah, great response in the chat box. Yeah, people are coming. Yeah, age, congenital eye disease, chronic disease, all of these things can actually predispose somebody to having a cardiac surgery. So let's crack on. Thank you. Cool. So in terms of the procedure, common procedure we can find on cardiac ITU or cardiothoracic ITU or on the cardiac ward, in terms of common procedure you can find, I will try as much as possible to keep this very, very simple so we can perfectly understand the message. So generally, due to the advancement in medicine these days now, you can find some procedures that are just minimally invasive, that are not like the common one, the traditional one. We'll find like this first picture here. This is just an open heart surgery, open the sternum, open the thoracic, the surgeon, looking directly into the heart, doing their stuff there, which is good. But at the same time, these days now, in terms of modern advancement in technology and everything now, these days you can find some procedures that are just non-invasive, that are minimally invasive, that might not warrant the surgeon to open the sternum, the thoracic cavity this way. You can find some of them that you just need to pass a catheter through the groins, through the femoral artery, directly into their heart. You can find some of them as simple as that. So in terms of, forget about names of all of these procedures, first of all, let's think about our physio first of all. We are not surgeon, we are physio. So how does these things relate with our job? If somebody have got a big wound in their chest, they've undergone open heart surgery, and you've got somebody that they just have a minimal cut, or they have a minimal cut in their chest, or they just pass a catheter through the groins, through their femoral artery in their leg, and that goes directly in their heart. So now, if you've got somebody that got a big wound and somebody that got a minimal cut, how does that link to our physio? What does that mean to us as physio? What does it mean to us as physio? Can I just quickly get some quick response on that? How does this impact our physio? What does it mean to us? What should be coming to our head? Suppose I'm reading patient caseload and I'm seeing in their case, oh, this patient, they had stenectomy, they had thoracotomy, or they have simple thing, they have open heart surgery, and you are reading someone else's note, and what they've written in their note is, oh yeah, they had a minimally invasive cut, or they have a non-invasive procedure. So what does that mean to us as physio? What should be coming to our head? Forget about all of these names first of all now. So let's start from basic things. So what does that mean to us as physio? Anyone ready to help us? So we are here to just discuss, to simplify all of these things, yeah? So what does that mean to us as physio? Pop response in the chat box, and if you also like to talk, you can raise your hand so that everything will not be, yeah? So what does that mean to us? Open wound versus minimally invasive cut. What should be coming to our head as physio? How does that impact us as physio? What does that mean to our patients? And what does that mean to us as physio as well? All right. Anyone ready to help? Anyone ready to help? Anyone ready? Anyone ready? Somebody have got big wound in their chest. They did an operation that involved the surgeon to open their chest. And somebody have got just very, very tiny cut in their chest. Or they just pass one catheter through their leg, it goes directly into their chest, no cut in the chest. So what does that mean to us? Does that say anything to us? Suppose you are reading their note, you are reading their postoperative note, you are reading their surgical note, their medical note. So what should be coming to our head? Are we still here? I'm just speaking to myself. Hello? Hello? Oh. Hello?
Yes.
Sorry, are we still here? Hello?
We can hear you, sir.
Oh, all right. Thank you very much. Thank you very much. I thought my network, I've been speaking to myself. Yeah, thank you. Oh yeah, great response. I think the one with minimal cut, we have better prognosis and less complication. Perfect. Great stuff. Very brilliant. Yeah, the one with minimal cut, we have a less complications, higher chance of recovery. Great stuff. Brilliant. Yeah, great. Yeah, thank you for confirming that you can hear me, Peter Amara. Yeah, thank you for that. Peter Fumlayo, I think early mobilizations can be done for people with minimally invasive procedure, once vitals are deemed stable. Perfect. Yeah, good job, good job, good job, good job. Yeah. Any other thing? Yeah, of course. From patient perspective, somebody that have got a big wound, we expect lot of pains. We expect, you expect from human point of view, you expect the person maybe to be anxious, you expect load of attachment, you expect now they just had heart surgery. They expect their cardiac issue, their heart rate, their cardiovascular system to be fluctuating. You expect attachment, you expect pain, you expect some kind of muscle guarding, you expect in terms of minimal cost, you expect the person to be less pain, quick recovery. What else? What else? Like we are thinking this thing together. What do you think? Less complication, less post-operative complication. So somebody that they've opened their chest, if they've opened somebody's chest, they may likely come up with complications, pneumothorax, they are prone to pleural effusion, they are cardiovascular issues, their heart, they can have atrial fibrillation, they have touched the heart. Heart does not like to be touched. Our organs does not like to be touched. But now somebody have touched them. So they are likely to be fluctuating. So these are what should be coming to our head as physio. All right. So now all of these things are directly linked to our procedure. That is the first message for the day. Whenever we are reading patients, pay attention to the kind of procedure they've done. Is it a big wound? Do you expect a big wound? Do you expect a small wound? Do you expect, and in terms of presentation postoperatively, we should be thinking in that lane. Oh, this person is like, and again, in terms of, for somebody to have had an open heart surgery, you expect that the length of time, the duration of time will be quite longer than somebody that have just had the minimal cut. And what does that mean to us as physio? We know that the longer the durations of your surgery, the longer the length of your procedure, the more chance that you are on anesthetic agent. And we know what anesthetic agent will do for our patient postoperatively. This is how we think as physio. Does that make sense? So, all right, in terms of different procedure you can find, let me crack on. Let's continue. You can find coronary heart bypass graft, cabbage. So what does this mean? These are just simple things. This is just, suppose somebody have got a plug or a block in their coronary artery. So we need to bypass that plug. So the surgeon can decide to remove a vessel, either artery or vein, from elsewhere in the body. Usually they might remove the artery in the hand, in the radial artery. They can remove radial artery. They can remove the artery in their chest, in the mammary artery, either internal or external mammary artery. They can remove that. They can also remove a vein in their leg. To do that, they can remove a Sabinus vein in their leg to do that. And again, you are going to the patient bedside. What does that mean again postoperatively? Suppose they've removed somebody Sabinus vein in their leg, and you've gone to see them in their day one post-op. That shows you won't be, aside from the consideration of their chest, like the wound in their chest, you should also be looking at the wound in their leg. That's what that means. So, but generally, there is no restrictions if they can stand, if they can walk, if they are very stable, no restriction regarding that. But you should also be looking about the wound. You should also be concerned about the wound in their leg, because there will be pain as well. This is how these things are linked to us as physio. If they remove someone's Sabinus vein, have you tried to check the strength in the leg? Have you tried to ask them to do some ankle range of motion, all those kind of things, just to check? You have reasons to be checking those things now. All right. So again, in terms of coronary artery bypass graft, it could be minimally invasive, or it could be invasive procedure, depending. For instance, now if somebody have just done, let's say, one coronary artery block, for instance, now they might just do just part a stent in their leg and just put a catheter just to that might be minimally invasive. And again, but if somebody have got, let's say, 3-4 coronary arteries, the surgeon might need that is a severe blockage in their heart. So the surgeon might need to open the heart and see what and see so that they can successfully bypass those areas of blockage, if that makes sense. Again, how does this link to us? If somebody, the same thing, just like what we just explained, if somebody have done open procedure, let's say they said they've got done invasive coronary artery bypass, you know what that means. And if they say they have non-invasive, now we know what that means, and we know how that is directly linked to physio, if that makes sense. And again, you should understand now that if they've said, oh, they've got a cabbage, somebody have done a cabbage, again, you should also read further in the note, where is that graft? Where is that graft harvested from? Is it harvested in their hand? Is it harvested in their leg? Is it harvested in their chest? Is it harvested in their mammary artery? Is it the mammary artery they've used? You also need to also be checking those things and be checking range of motion, be checking strength, be checking pain, swellings, and all of those things in that area as well, if that makes sense. Are we still here, please? Is it making sense? Hello? Hello? Hello, can somebody just confirm?
We are here.
Oh, all right.
We are
Thank
here.
you.
We can
We
hear
can
you.
hear you.
All right, thank you very much. Thank you very much. All right. So the other procedure here that you can also find very common is valve replacement or valve repair. So one thing I just like to let me go back to this picture here. So one thing I just like to talk about the valve. So the decision, these are, of course, everything here is decided by the surgeon, not by the physio, either for somebody to have a replacement, valve replacement, or to have a repair. That will be depending on the surgeon, and things they check. They also check into how complicated is that structure, is that valve, how complicated is it at the moment? Is it working well, or is it total blockage, or is it stenosis? And one thing about valve that we also need to remember here as physio is one thing of course, for instance, now let's say I'm talking about tricuspid valve. This is the valve between the right ventricle, the right atrium, and the right ventricle. So you expect this valve to be like a gate between the two chambers. You expect this valve to be like a gate between these two chambers to allow blood to only flow in one direction. So now, if this valve is stenotic in the sense that it becomes stiff, what will happen? Difficulty for blood to flow. And again, this valve can also be fluffy, like can also be fluffy. And what that means is it lost full control. In that regard, blood might start flowing backward. So if you look at the valve here, let's make it a bit more reasonable. If you look at the valve here now, so what I'm saying is two things generally. All right. PT Abdul, please. All right. If you look at the valve here, two common pathology we are trying to discuss here is that you've got narrowing of this valve. Is that you've got narrowing of this valve, that the valve becomes stenotic. Blood cannot come out of this valve. Or you have this valve, they become leaky. Blood is flowing backward. Ideally, blood should be flowing in a unidirectional manner. It's a one-way flowing. Blood comes through the right atrium, it goes to the right ventricle, it enters to the left atrium, it goes to the left ventricle. From the left ventricle, it goes into the aorta directly. That is how blood flows. One way, it does not flow backward. Blood does not flow from the left ventricle to the left atrium. It does not flow that way. Now, if blood starts flowing backward, that's a great pathology. So before you know, your patient, of course, common symptoms you can find. Sometimes if you go even before their procedure or something, you might find this patient, they might be short of breath, there might even be chest pain, there might be swellings in their leg, you'll find some of these, some might be, there might be palpitations, all of those things. And so now, in terms of replacement, in terms of decision to make, either to replace or to repair. So that will be based on what is the pathology at that moment. So now, in terms of, let me find the picture. So we can have atrial valve replacement. So you can also, so in terms of replacement, this valve can be replaced by either mechanically, or it could also be replaced by animal valve, by animal structure. So now, one thing we need to remember here that is very, very important to us as physio is this. Now, if somebody have got mechanical valve, they have replaced their valve with a melter, with metallic structure. So what that means is that patient, in terms of medication, that patient might likely be, of course, they're going to be on blood thinner, anticoagulant, warfarin for the rest of their life. And what does that mean to us as usual? If you are reading their notes, now you know that the procedure they've gone through, they've had a metallic heart replacement. Of course, I expect you to, of course, check check their drug chart, look at their drugs, or you speak with the doctor. Of course, this is what they should be, even without you prompting them. Of course, they know that this patient needs to be on anticoagulant, they need to be on blood thinner. And again, what does that mean? Somebody on long term, let's say now they've even, let's say random patients now, they've had maybe heart replacement or valve replacement in the past 5 years, 7 years. Now they have been admitted in the hospital and you are checking their blood and you are looking at patients INR, for instance, and you are seeing INR of 2, 2.5, 3, and you feel like, oh, this is high. But now, if you go back to their background, their comorbidities, and you've seen that they've written there that this patient have had, let's say, metallic replacement, aortic, what's it called now, atrial valve replacement some years back. So that should send something in our. That means that patient, they are likely to have been on long-term anticoagulants, and this is going to affect all of these parameters in terms of their high NR and all of these things. Oftentimes, what you see when you read the note, or let's say they are being poorly now, they are being readmitted into the hospital, you might find medical team on the ward, they might say, oh, the target INR for this patient between this and this. Sometimes they might say between 2 and 3, sometimes they might say between 2.5 and this, depending on your patient group. So you shouldn't be worried with some of those parameters. That is the point you need to remember here from physio point of view. And we know, generally speaking, you know, if patient is not stable blood-wise, like in terms of INR, platelet, and all of those things, you know that they can spontaneously bleed. But in their own case, you've got good reasons if their INR appears to be deranged to you, you've got good reasons to think that, oh, this patient, are they on long-term anticoagulant? Are they currently on anticoagulant? So you have good reason to speak with their medical team for acceptable blood range before you go in to do your stuff, if that makes sense. So so what have you said there? So we have said for somebody to have a repair and for somebody to have a replacement. Of course, for somebody to have a replacement, that should be a very, very bad pathology. But for repair, somebody can also have a repair. For instance, now there is another procedure we call, let me go back, sorry, that we call TAFI. TAFI is transcatheter aortic valve implantation. Let's say in your patient aortic valve now, TAFI is not a replacement, it's not a, what's it called? It's not a replacement. It's just you passing a catheter. What the surgeon, what they do is they will pass a catheter through the leg. They will pass a catheter through they will pass, what am I saying? So what they do with TAFI is you are not removing the hold, the normal, what God has created there, the normal aortic valve. But what you are doing is you are putting in a new one on top of that to make it more patent. That is what that means. You are not replacing completely. You are not removing the old one. You are not surgically removing the old one. But what you are doing is you are bringing in the your prosthetic valve, and you are putting that on top of what your patient have got initially. And what does that mean? TAFI, so that means TAFI is just minimally invasive. It's not like open heart surgery. It's not like we need to widely open your patient chest and we start replacing. No, that's not how it works. Yeah, if that makes sense. So now, some other things we need to also be aware of. Maybe I just use this picture. Some other procedure you can find is you can find what is this? This is a stent. This is a stent. Stent can also be passed from the groin. Let's say somebody have got, I talked about cabbage the other time. If somebody have got a blockage somewhere in their coronary artery, they can pass this stent, angioplasty. They call it angioplasty. They can pass a catheter through their leg, and they will just put that. They will look at it under camera. Then they will pass that to open up the what's it called? The plug, the area that has been blocked. You can see it here in this picture here. So they can pass a stent. That's a stent. So all right. So that's that about that. So now so let's move forward. So I would like to also talk about aneurysm here. So in terms of aneurysm is just, of course, the bulge. You can see the bulge. The bulge, you can see the bulge in your aorta. And we all know that aorta has different parts. The hack of aorta, the root of aorta, the hack of aorta, the descending part, ascending part, and all of those things. So, but what you need to remember here is that bulge can also be anywhere in the aorta. That bulge can be anywhere in the aorta. So, and again, one thing about aortic aneurysm is this: most of the patients with aortic aneurysm, most of them don't even make it to the hospital. Honestly, if this is not being detected on time, if this aneurysm is not being detected on time, most of the patients will finally die. We can imagine this: if this weak part becomes burst, what will happen? There will be internal bleeding, and the patient will die. But if this thing is being detected on time, of course, a stent can also be passed, usually, sometimes. And this repair here could also be two things. Sometimes they can have open procedure, and sometimes in some patients, they could also have minimally invasive, where a stent is being passed through their leg and directly into the aorta. So that can also be done. So depending on where the, depending on where the bulge is, so your patient can have it. They can have it at the root of the aorta. It could be at the hack of the aorta. It could be hack of the aorta. It could be the ascending part. It could be descending, depending on wherever the bulge is. But what you need to remember here is this: you are reading the patient caseload. You are looking at, have they got open heart surgery? Have they got minimally invasive surgery? Have you correlated? Have you looked at the length of their procedure? Is it 2 hours? Is it 3 hours? Is it 4 hours? Is it 5 hours? Great. Then again, what else do you check? You also look into their background before they go into their procedure. Where were they in terms of mobility, in terms of their endurance, in terms of their physical activities? How were they doing before they come into for the surgery? Because all of these things will also determine how they will be presenting post-operatively, if that makes sense to somebody. So so that's that. So TAFI, I think I've explained TAFI. TAFI is not, you are not removing anything. You are just placing your prosthetic valve on top of the one your patient have got, and just to make it patent. And usually it's the minimally invasive. It's not an open heart surgery. So, and again, minimally invasive, we know what that means from us, from physio point of view. All right. Please, is it making sense? Are we getting one or two stuff? It's really difficult to teach this way, honestly speaking. Is it difficult? I mean, are we getting little things? Is it making sense a bit? Can I get a response, please? Was there anything you want me to clarify? All right, let me read the chat. Yes, thank you very much, PT Fumilayo. Yeah, can I get a few more response? Yeah, thank you, PT, excellent. Yeah. Just to check that if we are following, if we've got any concern, questions, or anything. Can I have a few more response?
Please, I have a question.
All right, go on, ma.
Yes, you said that it means something to us, minimally invasive or it's open heart surgery. So what's the implication of minimally invasive surgery?
What is the word? Sorry.
The implication.
The implications.
Of minimally invasive surgery.
Yeah. Is it from physio?
Yes,
yeah, great. Yeah, from physio perspective. So if somebody has got minimally invasive procedure, so what it means to us, the way we should be interpreting that is great. Small wounds, small cuts, good chance of recovery. In fact, depending on other things, most of the time we might not even necessarily have to see some of those patients. Let me say that again. If other things are fine, we may even not necessarily have to see some of them because they should be fine. Because minimal invasive is they just pass a tiny cut, small cut. Some of them, even before you go to see them, day one after their surgery, even the nurses, they could have even got some of them to sit out in bed. They I've even started telling some of them, do deep breathing exercises, walk around on the wall, go to the toilet, they are fine. So if your patient has already started doing some of those things, you don't even need to see them. Yeah. Compared to somebody that have now had open heart surgery, they've opened their chest, they opened their sternum, they use their rib retractor to retract their sternum. They use what's it called now? Saw to break their ribs. Think about that. They are breaking their ribs to penetrate into their heart. Big wound, big pain. Some people acceptance. How about acceptance? Some patients might even be anxious. Some patients might even be struggling with acceptance. Some patients might even struggle. Some people can even be cardiovascular complications. All of those things would likely set up compared to somebody that have minimally invasive. Minimally invasive from physio point of view, yeah, we may not. Big question mark. Am I going to see them? Big question mark. Less pain, quick recovery, less wound, all of those things. So that is the way we need to be thinking about them, if that makes sense. Did I answer your question, ma?
Yes, sir.
All right. Thank you very much. Yeah. Can we have a few more questions?
I've got a question.
All right, ma, go ahead.
Okay, so with the minimal surgery, wouldn't they be confined for, let's say, atelectasis? It's minimal. Maybe wouldn't there be issues with maybe reduced lung volume or even retained secretions in this kind of patients?
All right, thank you very much. So if you look into somebody that have got open heart surgery and somebody that have got minimally invasive, same thing for abdomen. Let's say even the same thing for abdominal surgery. Somebody have got open abdominal surgery and somebody have got small cut, laparoscopic. It's open wound, open abdominal surgery is laparotomy. Small one, laparoscopic, small cut. If somebody have got a small cut, either abdomen or thoracic, the chance that they will have postoperative complications like atelectasis, like pneumothorax, like secretion retentions, like increased work of breath, the chance is really, really very slim. Think about it. The length of anesthetic agent. You remember again, for somebody to have, let's say, open heart surgery, is going to be a very, very big one for patients. They need to break their ribs. What does that mean? That patient needs to be sedated. Most of them need to be they need to be sedated and paralyzed. So now, and again, in terms of length of the procedure, it could be 3 hours, 4 hours, 5 hours. Somebody will be lying down in bed. In fact, I'm going to just show you in these presentations. Some of them might even need to be under their heart and the lungs can even need to be bypassed, meaning that they will be connected to the ventilator. The ventilator will be doing the breathing for them because they've sedated them. They are sedated. They are paralyzed. They don't even know what is going on again. Let me put this in way. So now, for somebody to have those medications, for somebody to have those medications, not like sedative agent, paralytic agent, they don't know what is going on. What does that mean? If you think about from physio point of view now, in terms of their lungs, their mucociliary activities is not working. They are not able to cough. The sedative agent will not. Oh my God! The sedative, please now. The sedative agents would, of course, depress their cough reflex. They won't be able to. Of course, they are even unconscious at the moment. They won't be able to do all of this. And again, in terms of length of surgery, imagine somebody lying on surgical table 4 hours, 5 hours. They are not eating, they are not drinking, they are not taking deep breaths, natural deep breath in. It is the ventilator that is doing those things for them. What does that mean? The chance that after the surgery, they will be dehydrated. That is why if you go in to see some of them, day one post-op, some of them will be dehydrated. They're very dry. Somebody lying down for that. And again, not just because they are lying down, those anesthetic agents they give to them as well, those paralytic agents, those sedative agents, also make them to be very dry. And again, what dryness can do from physio perspective. You know what dryness does for our patient. It's going to make the secretion in their chest very, very thick, very viscous. They won't be able to cough and clear clearly. Before you know, they will start retaining secretions. And naturally speaking, what evidence has also shown is that patients patients that have undergone anesthetic agent, their lung volume is naturally reduced by 20%. Their FRC, their functional residual capacity, is naturally reduced by 20%. So put all of this into consideration. Anesthetic agents, longer duration, they are being sedated, they are paralyzed, they are not breathing. It's the machine that is doing all of those things to them. And again, think about it after the operation. Because of pain, some people will naturally struggle taking deep breaths. If you are not able to take in deep breaths, you won't be able to generate that expiratory flow, that big flow. You won't be able to clear your airway excellently. And again, even if you want to do that, some patients might be very anxious, they might be very, and it could even be very, very painful, putting pressure on that fresh wound. So think about all of these things. So all of those things further put patient at risk of developing postoperative complications. As opposed to small cut. Small cut, 1 hour, they are gone, they are done with the operations. Small cut, very, very small wound, not a big one. Even if it is abdominal surgery, small wound, not a big one. Patient, they've already, day one, some of them will be up. And again, we also need to put the background of the patient. No matter how small the cut might be, sometimes the patient is coming from a very, very poor respiratory background. For instance, let's say they've got COPD, emphysema, they've got bronchiectasis, or they've even got heart issues. They've got a long-term heart failure, they've got fluid overloads, all of those things. So even if their wound is really very small, some of them might still also come down with pulmonary complications. So, but what we need to understand here as physio is think about how all of these things could impact your patient even before you go into therapist. Because if you don't get this clinical reasoning well, that is why I'm spending this time to explain this area. If you don't get this clinical reasoning well, you might not really manage that patient. If that makes sense. Did I answer your question, Ma?
Yes, thank you so much, sir.
All right, Ma, thank you. So, all right, let's continue. So now, in terms of attachment, so we can find different attachments for a patient that have undergone cardiac surgery. You can find loads and loads of attachment. If there is one thing I'm going to tell somebody here is, if there is any attachment you are not familiar with, do yourself good to speak with the doctor, to speak with the nurses in charge, with that nurse looking after that patient, to clarify. Oh, this I'm not. I will sure. Just ask them. Ask them in the way you are very comfortable with. Ask them. Ask them. Is there any restriction with these things? Because this is not every time that somebody have undergone cardiac surgeries or thoracic surgeries that just go to their bedside. They are on drains. You don't even know if the drains is active drain or passive drain, and you want to get them out. It's not in every time, but I will still do a bit. I will still try my best to also, get us to be aware of some of those things as well. But what I would just say is, in reality, patient can be connected to different things. They can be connected to lines for medications, for blood pressure support. Don't forget, we are talking heart here, cardiovascular system. Somebody after the operations, somebody can be struggling with blood pressure. The heart rate can be jumping up and down. For instance, this one, this second one, what do you call this? This is called pacing box. Pacing box. Somebody that just did heart surgery. The chance is there that their heart, the regularity of their heart rhythm might be up and down. The chance is there. You might go to their ward and you find somebody on this pacing box. Just like their name. Just like their name, pacing box, just to pace the heart. If the heart is jumping, the heart rate is just jumping up and down. You need somebody to pace it. You might be on the pacing box. All right. You might find different attachment. You can find this one, this last one here. What is this, for instance? So this is swan gas. You can find chest drains. You can find different attachments. Please, like I mentioned, do yourself good to speak with the medics, to speak with the nurses, ask them, clarify that attachment. And if that attachment is being clear, great. Ask them, is there any restriction for these things? Are we able to get patients to sit out in bed with this attachment? Ask them, clarify that thing. Not just, post-op instruction. I go to their bedside. They've not said anything in their post-op. They've not said weight bear, non-weight bear, or do this, don't do this. Beyond post-operative instruction, when you go to the patient bedside, if there is any attachment based on where you work and you are not 100% familiar with, don't just move patients. You are not a technician. We are physios, we're trained people, speak to the medical team, clarify those things, because you know that there might be restrictions for some of these things for patients with cardiac surgery, if that makes sense. So what is this last one? This is pacing. You can find PCA, patient control analgesia. You can find pacing box. You can find attachment for medication, for anotropes, metronidazole, for all of these things, like that. So swan gas, just few things about swan gas. So this is a tube or a catheter that goes directly into the pulmonary artery. Usually you find that, I think I've got a picture, you find that in the patient's neck. It goes directly into the patient. They just put that through the, what's that? The internal jugular, or they put that through the central lining, that your subclavian veins, and they pass that through the atrium into your, what do you call it now? Into your pulmonary artery, through the atrium into your pulmonary artery. So what this does is this is just to measure, to look at the pressure of the heart. If your patient have got anything that is causing stress, or that is straining the heart, or that is causing too much of stress to their heart or to their lungs, think of any condition. Oh, they've got boggy heart, they've got fluid overload, they've got pulmonary edema, they've got it could even be somebody, if somebody has got PE, for instance, or if somebody has got, maybe they just did that surgery, or any conditions, anything that is stressing the heart, or that is straining the lungs, or anything, you can find patient on this. So now, what is the risk? This is just common sense. Common sense now. These things have been passed from patient's neck. They pass that directly through the vein, through the big veins, through the veins in the neck, and it goes directly into the artery, pulmonary artery. Imagine I just go to patient bedside. I just go to the patient bedside and I start. What is the risk associated with this thing? The risk is this catheter can further go down into that pulmonary artery, or this thing can get dislodged. Said, are you able to mute yourself, sir? So that is the risk. So now, if I just go to the patient bedside and I start moving them, I start shaking them, let's say they are now chesting now, I don't even put this thing into consideration, I just start shaking them and do this thing. What is likely to happen to this patient? It is either this catheter go further down, or it get dislodged. And there is a reason for having this in the first place. The reason is just to monitor the heart, to monitor the pressure of the heart, to monitor this thing, to monitor what is going on in the lungs and everything. So now, generally speaking, what I would say is, a patient is on these things. A patient is on swan gas. Generally, I would say, when they are on swan gas, leave them in bed. If you need to support them with, even if they are chesty at the moment, you need to support them. Think about what you need to do. Think about how you need to support them without causing this to either get dislodged, or to either get migrated down into their heart. If that makes sense to somebody. All right. So like I said again, you can find loads of attachment clarifying those things, stuff with your patient. All right. So another thing you can find in cardiac patient. So you can also find intra-aortic balloon pump. So balloon pump, let's say for instance, now let me just keep these things very, very basic and simple. You can also find this pump in a patient. Let's say, so for instance, now you've got a patient, they go, let's say MI, myocardial infarctions, or their coronary arteries are not working well, or a patient that are struggling. You know, the other time when I was explaining, please, are we able to, can you mute yourself, please?
Do I have control? Da kika ce min babu, shi ne magana ta wasan na gabe gani ba, na kira ki in ce miki kimar waya ta ce ba.
So I don't know what to do. So so like I was saying, If somebody have got intra-aortic balloon pump, let's say due to any reasons, let's say they have open heart surgery, for instance, now. So, and their heart and lungs are being bypassed while they're having this procedure. Then after their procedure now, their blood pressure is not okay, or or maybe the surgeons or the medics, they sense that, oh, they are at risk of myocardial infarction or something like that, or they just got maybe myocardial infarction, anything that can impact blood supply to your myocardium, for instance, now. Or maybe their cardiovascular system, blood supply to the heart itself is really, really very poor. They can support patients with the balloon pump. If that makes sense, I'm just trying to keep this thing very simple. They can support this patient with this balloon pump. So what does this thing mean? It's just a pump. You can see the pump. This pump goes directly into the aorta. Now, during systolic, when your heart is contracting, this pump will deflate. You know, when the heart is contracting, generally, that means your ventricle is contracting, they are sending blood directly into the aorta, aorta carries that blood to your systemic circulation, blah, 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 all those things. Now, during this systolic time, this pump will contract. So that will allow more blood to also flow out. And during diastolic, what happens? This pump here will open up. They will receive more blood. And while they are receiving more blood, this pump will also give that avenue to your coronary artery. Don't forget, even heart feeds itself during the diastolic period when they are resting. So this pump here will give more chance for your heart to be able to feed itself during the diastolic period. Just get that simple explanation. Let me take that again. Intra-aortic balloon pump, patient can have that due to load of reasons, anything straining your heart, anything causing problem to your heart that is making blood supply to your heart to be depleted, to heart itself to be depleted, can make somebody to have intra-aortic balloon pump, if that makes sense. Now, just think about it. There is a pump in the aorta. So during systolic, when the heart is contracting, of course, that pump will deflate. And when your heart is relaxing, they will get inflated. Don't forget, when the heart is resting, this is when your heart is getting refueled. They are getting blood. Your ventricle will close, the atrium will open, blood will start loading back to your atrium. All right. So now, during that period, this is when the heart itself find their way to be able to feed themselves. This is intra-aortic balloon pump. Now, how does that correlate with our physio? Let me quickly read the chat box. Somebody have dropped something there. Okay, all right. Thank you. Mute your mic. Great. So now, how does this impact our physio? Now, before I talk about how this thing impacts, generally speaking, what I've seen so far is there are two things that trigger. Okay, let me show you the picture before I talk about the trigger. So this is how this thing look like. Look at this picture here. This is how this thing look like. So now the balloon will go into the patient's aorta this way. Then this thing will be connected outward to this machine for monitoring. So in terms of trigger, there are usually two things that triggers the activities of this balloon. It is either done by ECG or blood pressure changes. Blood pressure changes also, blood pressure will be changing during systolic diastolic, all those things. So these are two things that trigger these things. All right. So now, physio-wise, what does this thing mean to us? You have been called, you are the on-call physio, you've been called to see patients that they've had intra-aortic balloon pump, they are sandy chesty, they are not able to cover and clear, blah blah blah, this thing. Now, when you hear that, what should come to your head? Think about cardiovascular system, their blood pressure, their heart rate. Think about all of those things. Their blood pressure, their heart rate might likely not be optimal. They might likely to be on blood pressure support. Their heart rate might also need to be supported at the moment. Think about all of those things. In terms of positioning, this is just common sense. Do you just think I can just go straight to this patient bedside and I will start repositioning them? Oh, sit up, let's roll side to side. I need to be careful because already this patient is being connected here outside. And don't forget, something is being put into their aorta just to make the contractility of their vessels to work well. So generally speaking, I would say if your patient is on these things, generally speaking, keep them flat, keep them lying on bed, whatever position where you work, whatever the position the MDT are being fit for this patient, keep them in that position. And again, even after the removal of these things, before you even do stuff with them, I'll still say again, clear them from your medics. So the point in some of these things that we are passing here today is beyond this beyond what you have seen in the medical note, beyond what you have seen read in their postoperative note. You should also be conversing with the medics if you are seeing something that you are not very familiar with at patient bedside, or again, if you are seeing something like this, like intra-aortic balloon pump, keep them in that restricted position, restricted bed rest position. Even if they need to log, even if you need to rogue, sometimes they might need to log grow them or something just to preserve what have been put into their aorta. And again, if you need to see them after the removal of these things, again, I'll still say again, we just give them 1 hour, to prevent any 1 hour. Of course, they will be under monitoring of the nursing staff, checking their blood pressure, checking their cardiovascular system and everything, checking for bleeding and everything, even after the removal of all of this, before you go into that makes sense. Please, are we getting any value from this thing, please? Is this thing making sense? Is it really making sense? Hello? Are there any questions or anything you'd like to ask?
We're with you, but the distractions are just too many. I don't know if the host should either mute these people or let them be put out of the meeting, please.
I'm sorry about that, but honestly, there is nothing I can do from my side. It's really, the distraction is just too much, honestly. I'm sorry about that. Sorry.
There's a way to mute them from the settings. That's the host. It's actually so distracting.
I'm not sure the host is on the meeting. No, I'm not sure, honestly. I'm not sure. I'm just so sorry about that. Yeah. So sorry about that.
Yes, sir. It seems maybe the hosts have been put out, MRTP. And the individual that I can see as the host there, please, is Miss Rita or is it Dr. Rita Ogidan? Can you help us, please? Maybe she's not even aware that she has been made host. Please, if you're still with us, can you help us out?
Thank you for that. Thank you for that. Yeah. Thank you for that. All right. So let's continue. Let's continue. ECG conductivity, we still find time to talk about this thing, because we also need to understand certain things about ECG. But I will leave this in this slides, but maybe later on we can talk about ECG relation with physios, because we need to be able to read basic things on ECG, make sense of ECG, and link that with our patient. But we'll discuss about those things later on anyway. So like I was saying the other time, for patients with open heart procedure, for instance, now, some of them might be on this machine that will bypass their heart, that will bypass their lungs. And again, from physio perspective, we have explained how we can make sense of these things. We are not surgeons. We are not going into the theater to do all of these things. Yeah. And again, let me say this, please. If there is a way for any of us that is interested in this area of physics, I will advise that if we can get that opportunity in our place of work, we can't just maybe go into what some of these procedures is really, really very amazing. Honestly, I've been there several times. I've seen it. The feelings of you looking at how someone else's heart beats, how looking at how someone's ribs is being retracted, how the cutting is being done. All of these things will also impact you as a person if you need to see some of these patients postoperatively. Honestly, in terms from empathetic point of view, you'll be more empathetic. You will be more because you have seen it. You have seen how somebody is being opened, how somebody, how their heart is being stopped, how their lungs is being stopped, how their heart rate readings and everything is being stopped, and how everything is being done by the machine. how everything is being prepared by the machine. And again, when they need to return those things back, how it's being done is really not great. I think the work in a very, very good facilities like that, big facilities, I think it's something that we can my gosh.
Howard, please, can you mute your mic? Howard, please mute your mic.
Okay. Is it true?
All right. So thank you very much. So it's really amazing if we can give it a try to try and watch some of this procedure. It's going to add a lot to our practice. It's really going to add a lot to our practice. All right. So now let's try to summarize everything we have talked about so far. From physio perspective, let's summarize everything, whatever procedure you have had, whatever surgery you have had. Let's try to summarize everything together. How should we be thinking if we are reading patient notes? What should be coming to our head? Now, I need every one of us to be an active player in this. Of course, let's use our chat box because it's already noisy on the meeting already. So now, median stenectomy. If somebody have had median stenectomy, how should we be thinking as physio? What should be coming to our head? If you just quickly pop that in the chat box to make it very fast. You are reading the medical note. What they've said in the PT Abdullah, please. Can you mute your mic, sir?
Okay, sir.
Thank you, sir. Thank you, sir. So now, if somebody have got median stenectomy, you are reading the caseload and what they've written there, median stenectomy. What should be coming to our head as physio? How should we be thinking? Now, median stenectomy, who is helping us? What should be coming to our head, clinical reasoning wise? What should be coming to our head? Just pop it in the chat box. Yeah. What should be coming to our head? What should be coming to our head? How do you think that patient is likely to be presenting? What kind of things do you think we should be asking from the MDT to help the patient? What kind of things do you think when we go to their bedside, we need to be doing with this kind of patient group? How do we think they are likely to be presenting at the moment? Yeah. So what kind of information, what kind of educations do you want to be giving this kind of patient? They've had the median stenectomy. Median is just midnight. Tommy, please. So what should be coming to our head? Who is helping us? Yeah. Who is helping us? Somebody that have had median stenectomy, how do we make sense of that statement? Yeah, somebody have written something in the chat box. Let's check. Chest pain, great, perfect, excellent. Pain, physio enemy, our worst enemy in this patient group. You go to their bedside, they are in pain, they are groaning in pain. How do we support their pain? Do you think we've got, what should we be doing if they've had pain? Yeah, PT, excellent. Thank you very much for that. What should we be doing? They are in pain, they are groaning in pain. Somebody that is in pain, do you think that we're going to have their attention? They will not be attentive. They will be fixing on that pain. Even from an empathetic point of view, we also want to think about how do we help them as well? Yeah, pain, chest pain. Perfect. Thank you very much. Yeah, let's have that response in the chat box, guys. Let's have the response. Let's have the response. Yeah, somebody have written pain, median stenectomy. Yeah. What kind of pain? What will happen physio-wise? What will happen to their arm movement? What will happen to the usage of the arm if they are in pain? What will happen to their chest? What will happen? Will they be able to pop? Will they be able to clear? Are they likely to be in bed? Do you think they will be well positioned in bed? They'll be smiling and waiting for that lovely physio to come? So how do you think they will be presenting in bed? Attention-wise, how do we think they will be? Yeah, let's check. Great job. Thank you very much. Shallow breath. Good evening. Yeah. If you like to speak, yeah. Yeah, go ahead, ma. All right. Yeah. Exercise intolerance. Yeah. Somebody with pain, somebody with shallow breath, increased work of breathing, the heart rate is jumping and down. Of course, there will be intolerance to exercises. Yeah. Even to us, they will be fixating on their pain. Great job. Thank you, P.T. Deborah. Yeah. All right. Can we have more? What happens to the range of motion in the arm? What happened to their chest clearance? What happened to the cough? What happened to their work of breathing? Yeah. What happened to their length of procedure? Is it shorter than expected? Do you think it's going to be shorter than expected? Do you think it's likely to be longer than somebody with minimally invasive minimal cuts? These are how we should be thinking for this patient group because of time. Of course, just like everyone have said, you expect pain, you expect minimal hand movement. That means for this patient with median stenectomy, I should also be concerned about, maybe sternal precautions. How do I, maybe, let's say the pain is well controlled now, how do I get them out of bed? I won't be pulling on their hands. All these things will impact on their wound in the chest, big wound in the chest. I won't be, so are we thinking about that? Sternal precautions, is there precaution? Have you spoken with the doctor? Have you tried to have you tried to go through that medical note again to see? Yeah, impaired cough due to sternal pain. Thank you very much. Good stuff. Yeah. So these are how it's not about I think it's just more of clinical reasoning things. Clinical reasoning. All right. Another one, cardiopulmonary bypass machine. How do you make sense of that? You are reading the note. They have said that this patient, they have this so procedure. They are in the procedure. They've had the cardiopulmonary bypass machine for these 4 hours durations of that procedure. What does that mean to you? What does that mean to you? How do you make sense of that? Because we need to know some of these things. If we don't know these things, you might not be treating your patient well. You might not be doing the best for your patient. You might not be supporting them well. You might not be doing that evidence-based practice. You might not be doing that for them. All right, cardiopulmonary bypass. Who is helping us? Who is that physio? Yeah, cardiac physios. Where are you? Yeah, let's see what you've got. Pop your response in the chat box. Your patient, you are going on the ward. Your patient have had your cardiopulmonary bypass machine for 4 hours. What does it mean to you as physio? What does that mean to you as physio? What does that mean to us? Let's discuss. What does it mean to us? Who is helping us? All right. Maybe we'll just take that with the length, the longer duration of an aesthetic agent. Let's take those two together. Yeah, who is helping us? The two, what do they mean? How do they impact us? I think we've talked about some of these things today, actually. So somebody with long anesthetic agent, somebody with sorry. So what does that mean? Somebody with cardiopulmonary bypass machine, in the course of their operation, their heart is being stopped, their lungs is stopped. The machine is doing the work of their heart. They are on ventilator. Their machine is the machine that is giving them breath, that is pumping air in and out of their lungs. They are not able to do that by themselves. That's what that means. Their heart is stopped. Their heart is being bypassed. The machine that is doing the work of the heart, that is doing the pumping and this thing, receiving blood that their heart's supposed to be doing. It is the ventilator now that is giving them breath, that is shocking air in and out of their lungs. What does that mean to us as physio? This is how we make sense of these things. All right. What does that mean? Thank you very much. Somebody have written something. Let's check. Yeah, PT Fumilayo, great risk of complication, reduced lung capacity. Perfect. Absolutely superb. Great one. Reduced lung capacity. How? How? Let's explain. How? Big stuff. Good stuff. How? Naturally, we are meant to be doing these things by ourselves. Now it is the machine that is doing these things for this person. They are on an anesthetic agent. An anesthetic agent, naturally, like I mentioned, evidences have shown 20% of functional residual capacity. An anesthetic agent reduces it. Again, they are lying flat. They are lying flat. They are being sedated. They are paralyzed. Their muscles and everything is not working. The tone in the abdomen is not able to support their internal organ, their viscera, their liver, their What have they got in the abdomen again? Their liver, their spleen, their GI, and everything. Their abdomen tone is lost. They are being paralyzed. What does that mean to you as physio? Even though they are on machine, the ventilator is the one doing the shocking in and out of the ear for them. What will happen? The abdomen are likely to be distended at that point. If it's not distended, do you think the abdomen and your pelvic muscles, the levator ani, all those things, do you think that muscles at that moment we have that good tone to be able to support your internal organ? No, there might be push. That your internal organ might likely push higher up because of effects of gravity and some other things impacting on your diaphragm. What does that mean? That patient might likely end up leaving the theater with atelectasis, lung collapse. They might leave the theater with lung collapse. If that makes sense. All right. So again, the effect of what do you call it? Effect of anesthetic agent again, taking away some of your lung volume. They might also leave the theater with lung collapse. This is how we think as physio. All right. Yeah, let's see. Because of ventilator, thank you very much, PT Formula. Yeah. Any other thing from this? And again, anesthetic agent postoperatively. Analgesic, this is how physio think. Anesthetic agent postoperatively. When you go to their bedside, what are likely to be their presentation? Anesthetic agent, some of them might be confused. Oh my God, think about that. This is how you think. Before you go, now if you now go to patient bedside and they are confused, you can link things up. You can link things up. And again, you can also go to their bedside again. Some of them might be feeling sick. They want to start vomiting. They want to start. This is normal. They are not running mad. This is normal for them. Because of what? It could be because of the PCA they are on, the morphine they are giving to them. It could be because of the anesthetic agent they've had before in the course of their surgery. If you go to patient bedside and they are feeling sick, you should be able to reason things together. And what do you want to do? Speak with the nursing staff to give them that antiemetic medications, to give them that anti-sickness medication. Simple. If that makes sense. How about their blood pressure? Anesthetic agent will impact on their blood pressure. And again, because of this anesthetic agent, because of the cut and everything, sensation changes. Some people might have sensations, poor sensations, sensory changes. This is how we think as physio. We should be able to link things up. If we don't understand some of these things, you might not be managing your patient well. I keep repeating that. You may not manage that patient well. The chance is very high. If that makes sense, there are a lot of things you can correlate together here. Let's see what we've got again from our lovely physios. Yeah, it's excellent. Muscle weakness. Perfect. Thank you very much for that. Because they are on paralytic getting paralyzed for a while. All right. Can we have more? Can we have much more things again, guys? Can we have more things? Clinical reasoning discussion. We are just discussing here. We are lovely physios, excellent physios. We are doing good. We are doing great. All right. What other things do you think? Anesthetic agent, somebody having bypass. Let's clinical reasoning things together. Yeah. Let's see again. Even paralytic. Perfect. Excellent stuff. Excellent. You might find patient postoperatively, especially for the abdominal surgery, for instance, you might find people struggling to open their bowels. You might find people struggling to open their bowels. Right. Any other thing? So by the time we go to the bedside, we are checking some of these things, not those physios that will just go to see patient and start doing routine sensation. And it's not every patient that you'll be doing your muscle strength and grading. It shouldn't be random things. It should be clinical reasoning led. Let me say that again. Muscle stretching, range of motion. It shouldn't be everything we should be doing for everybody. It should be clinical reasoning led. Clinical reasoning. If I now go to patient bedside and I'm checking their sensation in the leg, there's good reason to be doing that because they've had anesthetic agents. They've had a bunch of epidural and stuff and those things. I need to be checking their blood pressure. I need to be checking their heart rate because I know those things will definitely impact on those things. That makes sense. No routine physio. Everything they do is just testing muscles in everybody. There should be clinical reason why you are doing some certain things. That makes sense. Let's go to the next one. Please, ma. All right. Another one. Disruptions of cardiovascular system. Cardiovascular system, disruptions, their blood pressure, their heart rate. You can, most especially for heart surgeries. Most especially for heart surgeries. You might go to their bedside and you find their heart rate, resting heart rate, very high after their procedure. Why? This is reasonable. I mean, this is commonsensical because they've touched their heart. The heart rate will now be jumping up. Have you checked their ECG as well to look at your physio stuff to correlate little things? Have you checked? I'm going to talk about ECG later. Have you checked that? Have you looked at some? Have you checked for AF, atrial fibrillations? Have you checked? Because this is really, really very important. Very, very, very important. All right. Because of time, lines and attachments. Lines and attachment. How do we make sense of these things? You go to patient bedside, check for lines, attachment. Because attachment could, like I mentioned the other time, attachment could mean anything. You don't just go and just randomly do things. For instance, drains. Some drains can be connected to suction, active drains. You need clearance to move them. You need clearance. Don't just go there. Don't just go there and start moving them. Have you checked drains? I will talk maybe on the other part of this discussion later on. I will discuss about chest drains, all these bubbling, swinging, and those things. I will discuss about those. Have you checked for those things? Again, lines and attachment. Some might be on blood pressure support. Their blood pressure for some patient might be really low at the moment. Some might be on blood pressure support. Have you checked their dosage? You need to know these things. Have you checked their dosage? Oh, are they on metronidazole? Are they on this? Are they on that? Are they on NORADs? Are they on vasopressins? Have you checked those things? No. Have you asked the nursing staff? Have you speak to the consultants in charge? Have you spoke to them? That okay, yeah. My plan is to get these people up. If I see them edge of bed, their blood pressure drop. Are there scope for them to titrate? You don't just go to the bedside and just moving people no. In terms of mobility and transfer, let's say they are stable hemodynamically wise, cardiovascular wise, they are very stable, and you want to move them now. In terms of attachment, there has to be consideration. You also have to think, do I need to go alone? Do I need to go with my colleague? For attachment, to be able to manage attachment. And what I do in practice is, if I go, usually it might be 2 people postoperatively, depending on the procedure your patient have got. I might just go in, I might double up with any of my colleague or junior or anybody. What I will just do is I will check on the right side. What attachment have they got? I will check what attachment. The least thing you want to do as physio is getting patient up and you dislodge one of those attachments. You are it can happen accidentally. This can happen accidentally. But have you done your check? Have you done your check before you start moving them? From manual handling perspective, please, people, please, for God's sake, for manual handling perspective, have you gone? Were you there with maybe, for instance, now patients that are needing two persons to see them, you're not doing it alone. Are you a laborer? Think about all of these things. All these things this thing must be clinically reasoning based and led. It should be led by your clinical reasoning. Somebody have got open heart surgery, for instance, you know they are likely to be on load of attachment, all these things we've been discussing so far, and you are going alone and your plan for them is to get them out of it. What are you doing? Do you think, yeah, you can go alone if you've got limited staffing and stuff, but on the ward, have you also spoken to maybe any of the nursing staff or any colleague on the ward to help you? Think about all of these things. All right, less mobile patient. What does that mean to us physio? You go to their bedside, they are being poorly, their blood pressure is just off. You cannot work with their blood pressure, they are on high hanotropes. They are on a very, very high hanotropes. And some might even be on ceilings of hanotropes. Some patients might be really, really poorly after their surgery. They can be on high hanotropes. And you can't get them out of bed day 1, day 2, day 3. Day 3, they can't be on bed. What does that mean for you? What does that mean? I want you guys to talk here. So what does that mean for us as physio? Does it mean anything to us? They are not in bed. You are not able to do your stuff with them. They are drowsy. Their chest X-ray is just doing different things. Lung collapse, pneumothorax, dehydration, this and that. And you can't do stuff with them. You are not able to get them out. What does that mean? Less mobile patient. And again, aside from patient perspective, it could also be poor clinical judgment from the clinician. It could be poor clinical judgment from that physio. I won't say from the doctor. Do you know why? Because I expect, ideally, in a very good environment, I expect physios, they want to be able to be, even if it is elective surgery, even before they go into their surgery, pre-rehab them, do your stuff with them, do your, what do you call it? These are part of what ERAs are saying. See them before the surgery. If it is not emergency surgery, emergency procedure. So we should be working as physios to be able to look at caseloads, go on the ward, decide who do I see, who do I not to see, have that good clinical reasonings. Not until when somebody now bring a referral and say, yeah, come and see them physio. Yeah, it's good. Referral could work as well, but are we also working on being able to, if we are clinicians, we have our stuff, we know our stuff, we should be able to look at patient caseload and look and clinically reason some certain things and say, yeah, I think I need to see this person. No, I think I'm not seeing this person. We should be able to, we should be thinking now in that way, not blaming somebody, not blaming one consultant that was never trained to be a physio, not blaming him for not sending you a referral. You should blame yourself for not being able to go on the ward, look at the caseload, screen patient caseload, do your stuff. I know dynamics, hospital governance, clinical, wherever you work could be different, but are we also making effort to be able to do some of these things? This is what we should be thinking. This is what we should be thinking. And to be able to do these things, believe me, we need good clinical reasonings. We need good understanding of bloods, good understanding of all this procedure. We need good understanding of our own stuff, physio stuff. We need to know our own physio stuff. When I say knowing your own physio stuff, know what evidence says. I keep saying this. In this recent age, we need to be able to, I will say it again, we need to be able to do our own stuff perfectly well without doctor prompting you. Yeah, I need to be able to know when I need a doctor to help me. They also know from their own scope when they need me. All right, without wasting time, less mobile patient rather. That judgment could also be coming from the clinician as well. Some patients may behave good, they are clinically stable, they are hemodynamically stable, but we are not getting them out. What we are just doing is we just give them, what do we call it, spirometer, and we blame spirometer in bed. What are you doing? Get them out, get them to sit up, increase their functional residual capacity, get them to stand, get them to do some marching on the spot, get them to mobilize, increase their distance. All of these things are very important. These are what evidence says. If your patient is able, there's no reason why they need to be in bed. All right, more pain we have discussed because of time. Let's crack on. All right. Sorry, are we still there? Are we still there? Let me just... Hello?
Yes. Yes, sir.
All right, thank you very much. So, in terms of this fact, now, again, let me say this. I think I've mentioned it briefly the other time that it is not all patients that we need to be seen. This is where our clinical reasoning again come into place. This is where again, sometimes a patient on the ward, they are mobile, they are doing everything, it could even be just maybe small secretion in their chest, but they are still able to cough and clear it. You even find doctor, they will say, no, yeah, physio, are you able to say, can you see this patient for me? Or they will even send a referral. You should look at their caseload and see and just decline. I do a lot of that. I just read and say, I just look at them and say, I'm not seeing that. Because you should have that clinical reasoning. It is not everybody that you need to be seeing. And again, you also need to know people you need to be seeing. For the same thing, for post-op patient, just like I discussed when I was talking about abdominal surgery the other time, we should have a screening tools. And on these screening tools, things that we should have on that screening tool must be like things like their risk factors that could make somebody to fit in for physios. These factors that will make us to think of, to clinically reason that, yeah, I need to see this person. Things like, of course, like age, their age, and not just one, not just one, what is it now? Not just one criteria. All this thing might come with score, maybe age, maybe 3 or 4 or something, and we start ticking those things, things like that. So we can look like things like their age, of course, the older you are, the likely that you come down with complication, established comorbidities. Of course, if you've got previous backgrounds, let's say you are coming from a poor respiratory background before your heart procedure, you have COPD, you've got asthma, you've got bronchostasis, emphysema, all of those things, or you've got a very, very terrible heart in the past, heart issues in the past, or let's say you know your heart is buggy, you've got pulmonary edema, you've got megaly, you've got defect, you've got whatever things. It could be a risk factor. You are a chronic smoker. It's a risk factor. Functional status of a person. Are they normally limited? Are they unlimited? Is it moderate? Is it somebody that is just normally in bedbound or something? Is this so? These are we can easily correlate somebody that is coming from a poor functional status, functional background. They are likely to develop postoperatively compared to somebody that is normally independent. So how do we know these things? Through their social history. Through their social history. The social histories, even mobility status, is also what the medical team, they also consider before they walk somebody into their theater. They just look at random patient that is bedbound, that is very poorly in bed, and say, yeah, let's take them, let's get them to the theater. Let's open their chest. Let's give them that general anesthesia. Some people might not recover from that anesthesia. Some people will die. So they also look into their background of that, their mobility, background, baseline. This is language we want us to be using, not baseline. Not just look at somebody and say, somebody that got stroke 20 years ago, they come to your facility and say, yeah, I can walk miracle. What miracle? What miracle? That has come to their baseline. Think about something else. If they've now got new stuff on top of that, that new stuff is what you are treating, not their stroke 20 years ago. Same thing here. If somebody is coming from a poor respiratory background, or they are coming from poor mobility background, you know that those people, they are likely to have developed postoperative complication compared to somebody that is normally, independent, very active in their ADLs and everything. All right. And again, when it comes to our treatment plan and what we are doing with them, let's say, for instance, now somebody have got reduced exercise tolerance. They are not moving well. They are usually they fatigue quickly. They have swelling, short of breath because of their previous heart issues they've had. Now they've been housebound for like 20 years. But now everything just suddenly becomes okay for the family and everything. They've worked them in for the theater. They've done the operation for them. We still need to consider that their baseline again. That their baseline. We still need to consider that from physio perspective when it comes to our rehab with them, progressing them, and all of those things. Anyway, let's move forward because of time. Size of the surgery, of course, we can't emphasize that today. Is it a big cut? Is it a small cut? All of those things will impact. These are things we are also checking. On their postoperative note, generally speaking, we expect our surgeon to be documenting the size of the wound. 6 centimeter, this length of the surgery, 20 hours, 2 hours, 4 hours. These are what we are checking, and we are paying attention to those things. And you are also documenting those things in your note. Review postoperative note, the length of justice. These are what you are using to also build your own clinical business. If that makes sense. All right, length of the bypass, we have explained that. So these are some of those risk factors you are checking to decide if you need to see that patient or if you don't need to see them. If that makes sense. They are more than this. You can have nutritional status. Are they cachesic, or are they coming from a poor nutritional background? Maybe somebody dealing with esophageal cancer, GI cancer, now heart issues. Now think about all of these things. Because all these things will impact them postoperatively. We impact the way they will recover from that anesthetic agent, from that long line down, not eating, not drinking, dehydration, their mucociliary activities down, that paralytic agent, that sedative agent. All of these things will impact them. That reduction in their lung volume, all these things will impact their recovery. If that makes sense, right? So I'll just move away from here. Postoperative complications, of course, belt, CVA, we can relate CVA. How can somebody get CVA? In the course of the operation, blood clotting can happen. And think about somebody that has been on long-term anticoagulant, blood thinner for a long time. If they need to do surgery, of course, that thing needs to be stopped. If it's being stopped, they can have hemorrhagic stroke. And even postoperatively, if somebody has got AF increase the chance of blood clot. I think I explained this thing, in the last session as well. AF. If somebody got AF, or you are looking at their case and they are saying they have cardiac arrhythmia, this is how you should be thinking as a cardiac arrhythmia. That should prompt you to do something in their drug. I'll go check their drug. Oh, are they on appropriate medications? Yeah, check. But they are at risk. Ideally, they should be on prophylactic medication to prevent blood clotting. Have you checked their blood chart?
This
Check.
thing when the person comes, this is night.
Yeah.
Don't
Look
wear
at
night.
their drug chart. Aside from the drug chart, what else are you doing? What else are you doing? You're also monitoring their heart rate and everything. All right. But now, how does that increase their chance of getting cardiac arrhythmia or AF or something? How does that increase chance of getting stroke? If they get blood clot, if they have a blood clot, they can have stroke from there. They can throw embolus or something, or they can even have PE or something from there. Bleeding, of course, you expect bleeding. If somebody is having open surgery, you expect bleeding. What are you checking again? Link it up with your physio. If you are going to their bedside, have you checked their postoperative blood? Have you checked their HB? Have you checked some other blood? Don't forget again, if somebody is having open heart surgery, have you also checked don't joke with potassium. Their potassium, very, very important. Check their potassium. Check everything blood you need to check. INR, platelets, check those blood, because these people could have lost some certain blood in the theater. This is clinical reasoning kind of things, basic things. Now, the other one here that is a big red flag here is tamponade. What does that mean? It's just bleeding into the pericardium, the sheet that covers the heart. That's a big, big, big red flag for physio. You don't have to go in to see this patient. But what does that mean? The patient is bleeding into the pericardium. That will, of course, we know what that will do. That will compress the heart. That will compress the lungs. The patient may likely die of cardiac arrest. It's an emergency. They need to return this patient back to the theater, open it up, and just remove the blood from there. You don't have to see them. Arrhythmia, again, be careful with that. Arrhythmia, we have explained that heart does not like to be touched. Now they have touched the heart may be jumping up and down. Have you checked their medication? Have you checked with the medical team for their target heart rate? Listen, let me say that again. Target heart rate. Target. They should be documenting this. If they are not documenting, go and speak to them. So have you spoke to them for their target heart rate? If you really want to go to do stuff with your patient, if you are doing stuff, you want to do stuff, you should know this thing. Otherwise, you will just be, just be scared and say, just blow this, and you go. That's all that you can do for the patient. No. But if you really want to do this stuff, some of these things will impact you, and you need clearance. You need to clear what you need to clear. You need glucose. Infection, of course, everyone can relate to infections. Infection of touching their heart, external infection, wounds. They can get infection in the chest. Postoperative infections, how about pneumonia, how about not being able to cough and clear, bacteria, they love that wet environment, they love that anaerobic environment. Bacteria can easily grow in that area. How about wounds in their leg? Don't forget, like when I was explaining area where you can extract graft the other time, graft can be extracted in the leg, in the hand, in the arm. Check all these areas. And you should be teaching your patient. Of course, we expect nursing staff to be doing this anyways. Teach them how to care for their wound, checking for discharge, redness, and all of those things. Sensation nerve. If you're cutting the chest, of course, there are small nerves in the chest, all these intercostal, internal, all those things. You know their name. If you're cutting the chest, so of course, there will be sensation lost in the chest. Effect of anesthetic agent also impact on your nerve. We can relate these things. Right. I have had patients that even after some years after their stenotomy, they are still struggling to recover from the nerves in their chest. It happens. Pulmonary complications. What are the complications? Pneumothorax, pneumonia, this, and that. We can relate some of these things. We have spoken about them. All right. Some little things things you can manage. Complications you can manage. Let's discuss. You can manage somebody with poor cough. How can they have poor cough? Poor cough could be because they have reduced lung volume now. Anesthetic agent has reduced some part of their lung volume, or while they are lying down in the operative on the table in the theater, that might impact on their chest. I have explained that. It could be they not being able to take in deep breath and cough. Okay, shall we do something, guys? If I ask you guys to take in deep breath and cough, and the other thing is, I will ask you to just cough without deep breath. If taking a big deep breath and now cough, let's see. Now, just do normal cough now. one will be stronger than the other, which means that for us to be able to have a very, like for you to be able to clear your airway perfectly well, you need that inspirations. You need that big breath. You need to be able to do a big breath. Now you are going to see patient at the bedside. They are just doing shallow breathing, shallow and rapid breathing. They are not able to do a deep breath. You think they will have a good cough? No. And cough strength should be what you should also be checking, especially as physio. You know, cough is really very important. Super, very, very super for us as physio. We know cough is very important. All right, so you can relate. Don't forget, cough has 3 phases. For a patient to be able to give that big expiratory flow, that to clear the airway, inspiration must be really good. What is it again? You need the glottis to close up. That glottis need to close. You need to build up pressure. The glottis need to close. Then the third phase is you now need that expiratory flow to clear everything out of your lungs. Does that make sense? You go to the bedside, patient is having rapid shallow breath, definitely that will impact on their cough. That inspiratory flow is out of it. If that inspiratory flow is out of it, what does that mean? They won't be able to clear their airway. And you can do something as physio. All right. Reduced functional residual capacity. I will explain some of those things today. I won't go back to that. Muco, thick muco. You can also relate. How can somebody have a thick muco following their son? It could be they are dehydrated because they have their mucociliary action has been done. They've been on bypass, heart-lung bypass, all those things. No. So what do you want to do from physio perspective? If they are on dry oxygen and you have gone to see the patient at the bedside and they are on dry oxygen, what do you want to do? You want to advise the nursing staff. You want to swap that oxygen to liquid oxygen. If you are going to their bedside now, you see that what they are clearing, even if they are clearing, what they are clearing is really very dry, or they are looking dry. What do you want to do? Do you want to have the doctor to give them some nerves, to prescribe some nerves for them? This is you physio doing your stuff. You physio doing your stuff. You want to tell them to prescribe some nerves, depending hypotonic nerves 0.9. If you feel like, yeah, you've been seeing them 1 day, 2 days, you have monitored the secretion, the nurses have also gave you some feedback, and have them prescribe some hypertonic nerves. Give them 7%, 6%. Give them carbon 16, mucolytic. Give them those things. You tell them, they will do. But if we don't know these things, definitely we should be the one, because doctor don't do chest physio. This is job of the physio. Now, this job has been, I don't know. So we need to be doing our job. We really need to be doing our job. You tell them, prescribe this. Somebody that is not doing chest is now the one looking at patient and just like, they won't be able to do perfectly. It is you. You are dealing with secretion. You are dealing with these things. Tell them to give them these things. Or win them. In fact, if you need to win those, what do you call it now? Those nebulizers again, like from 7% hypertonic, you can say, oh yeah, now you can bring it down to normal saline net 0.9. Now secretions, because at some point, by the time you say, oh yeah, okay, give them mucolytic, give them carbon 16, combine them with what is it now? Combine them with hypertonic 7%, QDS 4 times in a day. You tell them this is what we do. You tell them 4 times in a day. Doctor prescribe 4 times a day. Will do. Speak with them, nurses, give them nebulizers on the ward 4 times in a day. By the time you bombard all of these things together and their secretion is now softening, they are now clearing easily and everything, you still tell them again, oh yeah, let's start winning this thing down. Oh, stop carbon 16, stop hypertonic nerve, stop this, stop that. This is why we need, these things are just clinical reasoning things. This is clinical reasoning things. Very interesting things. All right. So VQ mismatching as well. VQ mismatching. I think in the last acute this I have explained this one, so I won't go back to that again. Ventilation, perfusion stuff. But the idea I will say here is postoperatively, a patient that is standing, just understand these things. A patient that is standing postoperatively is better than a patient that is sitting. Is that making sense? A patient that is sitting is better than a patient that is lying down. Let me go again. A patient that is standing is better than a patient that is sitting. They said patient sitting is better than patient in semi-fowler. Well, that's okay. Let me say sitting in the bed. A patient sitting in the bed is better than a patient lying down. This is how you think as physio. Not go to every patient bedside. Hey, they have this surgery. Give them spiral. Patient that can walk. You just say, put them on bed and start playing. What are you doing? So think about these things. All these things you can relate with your lung volume. I put this thing here, but I don't think I have the time to explain this thing. Very simple concept. Very, very simple concept and very interesting. All right, think about these things. So your goal, when you are going to their bedside, your goal is, oh, can I get them to sit out in the chair? Can I get them to stand, maybe a few minutes, sit out in the chair, do whatever I want to do in the chair, deep breathing, thoracic expansion, just do those things in bed if they are able. If they are able, now think about what can we do in bed? Let's get them upright in bed. If there is no contraindication, remember, this is cardiac. Somebody can be on that intra-aortic balloon pump. Not every patient you can randomly go. Screen before you do anything. Screen everything. Screen the medical note, screen the nursing note, remove every red flag. Look at their bedside observation, their heart rate, blood pressure, everything okay before you do some certain things. But don't forget again, your job is both competence and confidence. You need to be confident and you need to be competent for you to be a great and a good acute physio. Because you are dealing with life-threatening things. And believe me, if you don't do enough, it will impact your patient. If you overdo, it will impact your patient. This is where confidence and your competency comes in. If this thing is making sense. Oh, pleural effusion, physio, pulmonary edema, pneumothorax. Can we fix all these things? The answer is no. You can't fix pleural effusion. It's physio non-amendable. You can't fix it. But pleural effusion, depending, this decision will be made by the medical. Sometimes they might pass chest drain. Sometimes they might say, and again, from physio point of view, if a patient is able, like they can sit out, they can stand, they can mobilize, believe me, their body will naturally shock away that effusion or that their fluid or whatever they've got in their, or that their hair they've got in their pleural cavity, if they are able. But if it is a big one, they might need to pass chest drain. If they are on chest drain, I can do my stuff safely, get them out of bed. If they are not on active drain, to get them out of bed, get them to mobilize with the drains. That immobility will help their draining and everything. I will talk about those things later on in the other part of the cardiothorax, definitely not today. I think this thing makes sense. So that's it. That is it. So for somebody that is fluid overload, that their heart is also wet and boggy and swampy, pulmonary edema, it's not physio amendable. But how do you, this is the problem again. How do you now differentiate between somebody that is thirsty, that has muco, that has phlegm in their chest, and somebody that has pleural edema? Let me get us to speak here. This is really important here. Are we still there, please? Hello? Hello? Hello?
Yes, sir. We are with you, sir.
All right. Thank you very much. Thank you. I appreciate it. So my question is, as a physio, you will get referral on the ward that will say chest review, chest physio. For a patient with pulmonary edema, that is fluid overload, fluid everywhere. How do you differentiate those patients from random chest patients, like normal secretion in their chest? How do you differentiate them? Okay, I will proceed. I will leave us to pop those answers in the chat box because of time, but I will proceed. Let's continue. All right, so pre-rehabilitation and enhanced recoveries are also evidence-based stuff. If it is not emergency surgery, like I said initially, we need to be seeing patients need to be seen before their procedure, do our stuff with them, provide education, families, what to be expecting, what to expect after their surgery. From physio perspective, you are not a doctor, leave those medical aspects for the medical team. They will also do their own part. But from physio perspective, what do they expect? What is likely to happen after their surgery? Physio, what you can manage. This is what you are going to their bedside to discuss with them. Exercises they will need to be doing after their procedure. This is what you are doing with them. You can also do inspiratory muscle trainings and all of those things. They are also evidence-based stuff with them to prepare them to optimize their lungs. their procedure, get them to, even if you don't have, just get them to walk around, get them to mobilize, get them to do a lot of thoracic expansion stuff, mobility, get them to the stairs, let them do stairs assessment, those things that can challenge their breathing, that can further optimize their chest, do those things with them if they are able before their procedure. All right, and a lot of course, nutritionists, they have their role. Dietitians, speech and language therapists, everyone has their role in this thing. It's MDT. It's not one somebody championing everything. It's not just doctor thinking you don't. No, it's everybody doing their OT, doing their stuff, physio, doing their stuff, speech and language, dietitian, everyone doing their stuff. Family doing their stuff as well, because family is also very important. We need family postoperatively to reassure them to families. Everyone is important. Everyone is important. All right, I won't stick with this. Some of these things here, I think I'll talk about them. Think about early mobility, think about your red flag, contraindications or anything. So I'll just keep that one. And again, bedside observation, like I said initially, is also important. When you go to their bedside, not just blood pressure, check their heart rate, check their temperature, check their oxygen level, check everything before you start doing your stuff with them. If they are saying there is pain somewhere, there is pain, look at that place, look at the wound, look at everything. Is it clean? Is it wet? Is there discharge? Anything, look at it. All right. So that's that. Look at I won't sit with that. I think I've discussed some of these things as well. Yeah. How about now? My patient postoperatively, they are poorly in bed. They are poorly in bed now. They need me to escalate some of my treatment plan. I'm not able to get them out of bed. They are not able to take in deep breath. They are, they are having secretion retention. Okay, let me just say this first of all. Maybe 3 things you want to treat in this patient. Maybe some of them might come down with loss of lung volume, atelectasis. They might have secretion retentions because of those things that we have explained. They might also have work of breathing. Work of breathing could be linked to many things here, actually. It could be linked to their heart rate that is being high. It could be linked to their work of breathing. It could be linked to their maybe respiratory rate is high due to any reasons. It could be that respiratory rate could be linked back to their respiratory. That heart rate, it could be maybe the fibrillation, the surgery they've had and anything. So it could also be because they are dehydrated. It could also, and sometimes this is why I keep saying clinical reasons. Sometimes you can also go to somebody's bedside, heart rate high, oxygen, they are on high amount of oxygen, they are having chest pain and this thing. Hey, it might not mean that it is their procedure. It can also be PE. This is why you need to be checking everything. Check ECG, what is their P wave, this one, that one, check this one, honestly. So, but they are just, this thing is just very rewarding. That is what that is why it's just very, very rewarding, seeing somebody day one really very poorly, not being able to do anything, in pain, groaning in pain and everything, high amount of oxygen, and you go in, you support them, you do everything physio with them to the extent that they're able to, do the stairs, they feel okay, and you discharge them. I have never seen anything rewarding in physio more than these things, honestly. Believe me, if you work in this domain, you understand what I'm saying. Honestly, some people can really be very, very poorly, especially if they are coming from a very, very poor background, and supporting them is really rewarding, honestly. All right, so so that is that. So physio-wise, if I need to escalate my treatment plan, let's say for instance now, okay, generally day one, what am I thinking about? Getting them up, getting them to sit out in chair, do deep breathing exercises. I want to also advise them do that deep breathing exercises hourly. Then sitting out in chair, I might say maybe do, if they are able, depending on my patient, under the monitoring of patient, but nurses, I can maybe start 2 hours, 3 hours, depending on my patient, 1 hour. I can make it twice in a day, and split it down 3 times in a day. Once I'm able to establish the numbers of assistants they need, once I'm able to establish the equipment they need, it is something that the nurses can also be doing. Rehab is not just when physio is around. Rehab is everybody. Rehabilitation is everybody. This is another thing again in our country. We tend to personalize. I have seen, it's something I've seen before. I've seen physio fighting doctor that why we fighting nurses on the ward. Why will you get patient out of bed? These are this is not just if patient is this is not them. This is not this is not, how will I put it now? This is not, they doing that does not mean, now I know in our country we are complex, but this is not just them. This does not mean now they are trying to say we are not important. Honestly. But again, if we start to do our job, honestly speaking, we will need these people to support our rehabilitation. Because rehabilitation, evidence-based, especially in this patient group, you want to have some of them sitting out in a day for every meals, for in the morning, in the afternoon, in the evening. You want them to be sitting out. So do you now need to be coming every time on the ward to be doing that? Or must it now be when you are around as the chief physio now to come and get them out? That is when the only time they can be sitting out. No, the nurses on the ward can do that with them. Their family member can. My own job, bro, is to establish, they need 2 persons to sit them out. They need to stick to that. They need this equipment to get them out. They need to stick to that. Because I know if they are not sitting now, they will not have that good lung volume. They will not be able to clear their airway very well. They will not start building that pain tolerance. And don't forget, pain is also another thing here. We've forgotten pain. Pain needs to be optimized. And again here, this is your number one enemy as physio, because you have little or nothing to do for pain. You only have to rely on your NDT. Can you carry your pens or cryo for somebody that have open heart surgery and you start massaging their chest? No, you need pain medication. You need to speak. But what you can do from human perspective is reassurance, encourage them, distractions, all of those things. Do those things with them. Some people might even be confused again. Think about those cognitive management we have talked about in the past. Bring those skills in here. These are soft skills that you can need there. All right. So now again, if they're in chair, I can do ACBT, thoracic expansion, all those things, blah, blah, blah with them. But again, if they cannot participate actively, they are being poorly at the moment, this thing. Think about some other things. And try IPP. These are some of the equipment we need in our country. Can do cover assist with them, talking here into their lungs, to clear here into their. And again, think about contraindication to these things as well. I will still discuss some of this positive pressure later on. Think about contraindication and red flag. Think about if somebody has got pleural effusion or pneumothorax, for instance, now. I might need to weigh risk and benefit. It does not mean on paper, yeah, pneumothorax, no positive pressure. Yeah, it's true. But in reality, you may need to do risk and benefit sometimes. You may need to speak with the medical team. What pressure should we start them on? Let's agree. What pressure? What this thing? These people are poorly. They are not doing anything. They are likely to die if we don't support them. So we need to do risk and benefit. Oh, what medication are they on? Have you checked their chest X-ray? Have you check all of those things and make your decision? All right. There are a lot of skills that are not also here. Manual skills is also here. Somebody have done thoracic surgery. Do you think you want to do anything from their chest? You can't do anything on their chest. Or you want to start jumping on their chest, percussion shaking. You can't do that in their chest. You may think about marking them, abdomark. I can do abdomark with them if they are able, if there is no contraindication, if they've not got any issue with the abdomen, I can do abdomark. So it's just clinical reasoning kind of things. CPAP is also here. If somebody has got lung collapse, they need somebody to splint open their airway. They need something, they need something to splint and open their airway. They need that continuous positive pressure to support them. Yeah, can get them on CPAP. And we can, on the CPAP again, we can still continue our prophecies, IPPB, everything we are doing to them. These things are what we can do with them. And again, once my patients are able, we have been mobilizing them on the ward. We start thinking about cardiac rehabilitation. And again, think about this thing. I think I finally put this one there. Day one, what are you doing if they are able? Like, let's say day one, they are able, I do 5 meters. Day two, I can increase the distance. If they are needing assistance of 2, I start decreasing the assistance. I'm looking at their gait. Some people might be having seasoning gait, all those kind of simple things. Their step 2 gait. Now let's progress them. Think about anything you can do with them. Sport matching, anything to progress their endurance, to improve their sensations and weaknesses in their leg. Think about those things. This is not tense based now. This is just simple mobility based. Think about all of these things. All right, respiratory support. Let's say they are poorly, before I've been using IPPB for them to give them a big breath, to support their inspirations, to recruit their lungs. Now I might start breaking it. I might start winning them on those things. Then maybe they've been doing BD, IPBB before. I may turn it to OD. I might start, getting that off, win it off completely, use mobility to support that. This thing is just patient dependent and good understanding of our treatment plan that we've got. Education, explain to them, let them understand why you are doing certain things. Get your patient to be actively involved, get the family to support them, get the nurses, use the nurses on the ward to support them, get them to sit out, explain the reason why they need to be sitting out, get them to be doing deep breathing every hour, get them to be doing deep breathing and cough, get them to be doing ACBT in the chair, get them to walk to the toilet, get family to walk them. Explain the rationale behind this thing to them, understand it first, and then explain to your patient. And once they are able, we start planning discharge, the rewarding part. We start planning discharge with them, let them go home. And before you send them home, check their ADLs, all of those things. All right. So the cardiac rehabilitation I mentioned here, it could be just 3 phases. The first stage is in the hospital. The second stage is when they go home normally. And the third stage is the rehabilitation part of it, the exercise program, the education and all other part of it, not in the hospital. You just have the first stage in the hospital anyways. All right, standard precautions. Time is going. Standard precautions. Somebody have written something in the chat box. Let me check. I have a question, sir. As regard encouraging patient, I have handled a patient though with a different condition, but usually do not like encouraging words. He says stuff like, just do what you are here to do. Do not say good or well done. Thank you very much. Yeah. And thanks for this question and sharing your experience. We have different patient groups. They present different patient groups. Some people, they just don't want that. Maybe they just don't want you to just maybe say some certain things to them. Maybe they don't want you to just encourage them to do things by themselves. And again, we need to also be careful with them. We need to be careful because there's something they call what's that concept again? I think institutional something. I cannot really remember that now. It means patients that can do certain things. Let's say they can dress up by themselves. If they are not doing it, maybe because they think the world will do it for them or the family will do it for them. Yeah, we need to be able to identify that okay, yeah, this person can actually do this thing, but they are not doing it. So as clinicians, we need to find a way we need to find that I would like that I think it's that to be able to find a way to encourage them to be able to do it, because we know that they being able to do certain things on their own, of course, is also part of their recovery process. Now, and if they are adamant, maybe due to maybe their behavior, or maybe due to cognition, or maybe due to the way they are just being stubborn or something, or they are just being adamant or anything, great. We also need to identify. So in this patient group now, why is this man saying these things? It could be different reasons, honestly. It could be cognitions, it could be behavior, it could be institutional, institutional dimension. It could also be that maybe the man was thinking, like, it could also be, maybe he was thinking that everything needs to be passive. Every treatment needs to be passive. So if you've got patients that normally think every treatment needs to be passive, then you now need to educate them. Come, I have my own role to do. You also have your own role to do. Education needs to come in. Now, this is what I'm going to give you some home program or what program or whatever. This is what I need you to do. This is also part of the treatment plan. Not me, not until when I come, you need to be doing. Physio is a continuous process. There are some certain things you need to be doing on your own. There are some certain things that also need to come to do with you. To encourage, because in fact, what the evidences are saying recently these days is active treatment. Get people to be doing stuff by themselves. Encourage active treatment. Now, if that is the case of that man, he might need education. It could also be cognition as well. Have we also screened that? Have we also screened? I don't know if it is outpatient level or inpatient or whatever, but have we also screened? Because some patient can be, especially active delirium, people can be pleasantly confused. Let me say that word again. There are some people that could be pleasantly confused. They are confused though, but if you are not if you are not a good clinician, you might not be able to know. They will be chatting, they might be smiling with you, but it could be in that case. So what do you do from there? If that is the case, what do you do? Support them, support their cognition, and also use your physio skills to get them to be doing things actively. Maybe this makes me remember some of the popular questions you see people asking about. Oh yeah, my patient wants TENS machine. Can I ask them to go and buy it? Why not? What is intense that somebody cannot use on their own? I'm sorry, but this is the reality. Promote active treatment. It is something people can manage. People manage respiratory equipment here, respiratory, CPAP, BiPAP on their own. They discharge patients with it. They manage it on their own. Promote active treatment. Active treatment. All right, that's just by the way. So it could be behavioral. We can also have behavior. There are different behavior in people. People can behave anything. You can also ask their family member. Before their surgery or whatever they have, how are they normally? You will need that family to give you their background. Now, if you are dealing with behavior now, then you need to know what to be doing. Now, if you are saying if it is that we impact on their treatment and they are not doing it, yeah, if they have capacity, patients have their right to make wrong decisions if they have capacity. If they don't have capacity, we will now start thinking about treating them in the best interest, supporting them. All right, good, great. So, spinal precaution is also part of what we need to be thinking about from physio perspective. So, I think this spinal precaution, it varies from center to center. It varies from maybe surgeon to surgeon. It varies from surgeon to surgeon as well. But there are mixed expert opinion on that. But generally, what you can find in people is if you have a read about Adams moving in tube, if you just put it on your Google, it's something you can have a read about it. It's all about teaching patients how to protect their chest. Let's say I want to get them up, I can ask them to have a roll to their side, do this, put their arms on their chest, roll to their side, and push up from there, just to protect their wound in their chest, especially people with open wounds. Like they need to break the sternum and to get access to their chest, something like that. So there might also be a lot of precaution, like before you start doing some rigorous things, it has to be 6 weeks or something. Some of these things again might also be something that might need to be coming from the surgeon, depending on the surgery, not you. And again, advising patients to even when they get discharged from the hospital, they need to keep working. Progressive things, gradual reintegrations. If they've had big operations, gradual reintegration and all of those things. So reduce our movement for a brief period of time, no rigorous hand usage, all those things. So something we might also need to be telling our patients as well. So that's that. So I think that's that for the day. Let me just take question. We might not be able to take this case study. I think it's something we can discuss on the page. And I also like to say this as well. We have not been engaging on those clinical case study, and I don't know. It's also an avenue where we can pass messages to ourselves, where we can share knowledge and all of those things. I think my words, engaging as well. So let me take questions before we end for today. Yeah, thank you, PT. Thank you, sir, for an unconscious patient as a cardiopulmonary physio. Aside positioning and percussions, what other interventions can we do? Yeah. So now, if somebody is unconscious, if you've got a patient that is unconscious and they are on bed, so what you will be doing with them will be led by their presentation. If your patient is in bed, if they've got evidence of secretion retention, if they've got secretion budding, they've got sec buddings, yeah, think about it. What do you want to do? Let's say they are being sedated, they are unconscious, they are on ET tube, or they've got trachea or something, they are connected to the ventilator. What do you do with them? Positioning is not the top of your skills. Everybody can do position. So, of course, we can encourage nurses to be doing it, not when physios are around. Nurses can also do position. All right. Part of your skills, you can mark them. Abdominal mark. If there is no contraindications to that, to support their cough, they need to be coughing. If they are unconscious, now unconscious patients, we don't know why they are unconscious. See, due to brain injury, is it because they are on sedative agent, they are on propofol, vitamins, and those things? Is it because they are on antroculum, paralytic agent, and those things? Is that why they are unconscious? We can also speak to the medical team. If they are being sedated, let's start winning this sedation. Because what is the impact of that sedative agent on your patient is that your patient won't be able to cough. And that cough matters a lot to you as physio. It should also matter to them. You should be the one educating them. Let's start winning this sedation so that patient can cough. Now, if they are on ET2, for instance, they can have, what do you call it now? Inline suction, closed suction. It's part of, you can sanction them. Physio can sanction them. Nurses should also be sanctioning them anyways, but it's part of what you can sanction them. Now, if you pass your catheter, you sanction. Let's say I go to bed, they're unconscious. I pass my catheter, I sanction, they are not coughing. I will think about what else do I need to do for this patient to support their cough. I know they're unconscious, their cough reflex is down, and this. I still need to do something to mimic their cough, or mark them, abdomen. If there is no contraindication, let's say they've got splenic laceration, they've got cut in the abdomen, laparoscopic or laparoscopic surgeries, or they've got maybe they've got bowel obstructions, or they've got anything in the bowels, anything in the abdomen. If the thorax is free, I can still mark them. I can do thoracic mark. These are part of what I can do for them. Okay. Now, again, if I'm doing that mark, I'm doing everything, I'm not clearing well or something, they still got secretion retention, I can cough assist them. I can bring my MIE, manual insufflation and insufflation, cough assist. I can bring that in. It's part of our skills. This is also lacking in our country. This is 2026. Do we say it is money we don't have? Or do we say we don't have patients that need those things in Nigeria? So this is where we need to be coming in, speaking to our authorities. We need some equipment beyond ends. Shortwave diatemy, those things are useless in acute hospitals. We need good acute hospital stuff. Those things are 100% useless in acute hospitals. Infrared, your shortwave diatemy is not useful in acute hospital. So we need to even start thinking about separating these things. Outpatient from acute. We need to build our acute. Acute is different from outpatient. People working in outpatient, they are doing great, fantastic job. People in acute hospital, we are doing great, fantastic job. We have different skill sets and knowledge. If you put me now in outpatient, am I likely to struggle? Because I don't have the stuff they have. I don't know what they know to be able to work in that domain. And if you bring some of them again to acute hospital, they are likely to struggle as well. So it is high time we start thinking, drawing lines on these things. Outpatient, MSK or neuro outpatient, that is what you want to be doing. Stay there, learn your stuff, know your stuff, be having seminars in that area. If you want to be acute, acute neuro physio, orthopedic, this thing, surgical physios, and respiratory physios, yeah, stay there and develop your skill set. So cough assist is something you can do. IPPB is something you can do for them. All right. So all these things will just be based on your clinical reasonings. But positioning is just, everybody can do positioning. Percussion, yeah, rib spring is something you can do for them. So all these things will be led with the patient needs, his patient needs. Let's say, for instance, now I want to recruit their breath. I want to increase lung volume. Now I can do rib spring for my patient. If my patient have got secretions, I can still do my vibes. I can do my expiratory vibes. I can do my percussion with them, fine. But if they are not clearing well, and while doing my vibes and expiration, I can still combine that with my sanction. But if they are not clearing well, how about that? I can escalate to cough assist. Yeah, sorry, sir. Expatiate on chest marking. Yeah. Oh, the mark is. Let me type that. I'm happy to type. Yeah. The mark is manual assisted cough. Yeah. Let me just say the manual assisted cough. So the mark is manual assisted cough. So abdomark is just put it on Google, because I may not be able to explain clearly here. That would be abdominal mark. You can use that for patients that are unconscious to support them. So while you are marking them, somebody can pass your catheter. Let's say I want to mark my patient. I want to do abdominal mark for my patient. I'm first of all passing my catheter to their carina, to their lungs. So by the time I'm marking them, somebody can begin to function. This is physio stuff. Nurses will never do this. But does it mean in our country we don't have patients that need those skills? So we need to start thinking about these things and think about how we can support our people. So any other question? Let's take questions. Let's take questions. There are a lot of things you can do, honestly, but it's just patient-led. It's patient-led. There's also VHI. Forgot that. Ventilator hyperinflations. You can walk your way with ventilator and give the patient a big breath to give them a long breath, to recruit their lung volume, ventilator hyperinflation. So we need to, if you are, if you are ITU physio, you need good understanding of ventilator. You need to be able to maneuver ventilator. These are physio stuff, tough physio stuff. I can still change parameters of the ventilators. I can look at parameters. Oh, do they need pressure support? If they are in work or breathing, maybe their respiratory rate is not optimal at the moment. I can take pressure support. Do they need the oxygenator? I can increase their PEEPs, all those things. So all these things will come with clinical reasons and good understanding of what we are working with. That's why I said, until we are able to partition our practice, if you want to be acute, stay acute. If you want to be community physio, stay with community physio. If you want to be outpatient, stay in outpatient and develop your skill set. All these things come with different skill sets and knowledge based as well. All right, thank you very much. Any other question before we end today? Any other question? Any contribution? Are we still here? Let me get feedback. Hello?
We are still here, sir. Thank you.
All right, thank you very much. Thank you. I appreciate that. Any questions? So in the absence of question, so thank you very much, everyone. Thank you very much. Okay, somebody have written something. Yeah, I have a lot of questions concerning mechanical ventilations. Yeah, great. What we say is, I would like you to preserve your questions till, I think a part of our training session also has this positive pressure part. So I'll be coming to discuss mechanical ventilations on that day. So you can pop in a lot of questions. I'm happy to take them. I'm really, really happy to take them. Honestly, I'm really happy to take them. So yeah, somebody also, yeah, so okay, I think this will be one of the organizers. So sorry for inconvenience. I made some of us here co-host. My phone will soon go die off. Thank you, sir. All right, sir. Thank you very much. I really appreciate your time. Thanks for choosing to learn together. Thank you very much, everyone. So we'll be ending here today. If there are further questions, we can put them in the chat box. Oh, somebody has written again, difference between SIMV mode and CPAP. Oh my God, I can take that. That's not a problem. So SIMV mode is what do you call it now? So it's just synchronized intermittent mandatory ventilations. Just think about these things in two ways. It's quite different from CPAP. For synchronized intermittent mandatory ventilations, it's just a mode on ventilator that you can use to support your patient. All right. So for CPAP, for that intermittent mandatory ventilation, that one will come with, let's say for instance, now I need to give my patient a breath. Let's say pressure support. I also need to support the oxygenations, like give them that constant positive pressure, PEEP. That thing will also come with it. All right. So now there is a part in this synchronized intermittent mandatory ventilations where my patient can do, where I can just, the machine now can do everything for my patient. And it will also come with a part again where the patient can also synchronize. That is where the word synchronize is coming, whereby my patient can also do their own breath. What I'm saying is SIMV mode now can give a mandatory mode. and can also give a breath that can also be coming from the patient as well. Spontaneous breath from the patient. It's both synchronized. You are synchronizing between the two. You are just mixing the two together. You are mixing spontaneous mode from the patient, and you are spontaneous breath from the patient, and you are also bringing in, what is the other one? Mandatory mode, mandatory breath. But the machine is also supporting with mandatory breath. Mandatory is machine is giving that to your patient. Let me just stay there because of time. Now, so when you say CPAP, CPAP is just, of course, you can find CPAP on both invasive and non-invasive ventilations. Non-invasive is all these. Non-invasive is you don't have to connect through the ET tube or through trachea or anything. It's just through the mask. That's non-invasive, if that makes sense. So CPAP is just continuous positive airway pressure. So CPAP just give PEEP, something like PEEP, positive end expiratory pressure. CPAP, that continuous means is it's through how the whole breathing phase, that pressure, that positive pressure stays in your patient's lungs. It splints open the patient's lungs through how the breathing phase. That is what that means. Let me repeat this thing. That is a concept we call PEEP, EPAP. What EPAP means, EPAP, PEEP, and CPAP, even they are all the same thing. It's just name and different, it works on different things. So what this thing means is that at the end of expirations, after let's say if I breathe out now, after I breathe out now, I don't want my lungs to collapse. Something must stay in the lungs that will hold up the lungs from being collapsed. That is CPAP, that is PEEP, that is EPAP. And that is equivalent to what I've been discussing so far, FRC, functional residual capacity, is equivalent to that. What that functional residual capacity does again is just something that remains in your lung at the end of expiration that does not make your lungs to collapse. It's still synonymous to your CPAP, to your EPAP, and to your PEEP. And all of those things are just for oxygenation. They just give oxygenation. They just split, because by the time your alveoli is open, then oxygenation will improve. If that makes sense, don't worry about that. We will talk about these things perfectly when we get to ventilation, positive ventilation. Any other question before we close? Hope I'm able to answer your question briefly, or you need more clarification, sir. Hello, sir. Do you need more clarification or anything? All right, thank you, everyone. Really, thank you for your time.
Thank you very much, sir. God bless you.
You too. All right. See you guys next time.
Thank you very much.
It's changing.
Thank you so much, sir. Sir, are we done?
Yes, sir, we are done, sir.
Hello, sir. So I think we are done for today. Thank you so much. We shall meet tomorrow. Thank you so much. Have a nice day.